Good evening, everyone, and thank you for returning to the second session of the ACP New Jersey chapter rheumatology meeting. Dr. Kothari will be presenting tonight, and any questions, feel free to reach out through the chat feature, or you are welcome to raise your hand and we can unmute you if you would like. Thanks so much and enjoy the series. Dr. Kothari.
Okay, thank you. Good afternoon, everyone. Last week, we covered a lot of territory. We covered high-value care, varieties of vascular conditions, which included giant cell arteritis, polymyalgia rheumatica, polyarteritis nodosa, Church-Strauss-Cogan syndrome. We discussed small vessel vasculitis, cryoglobulinias, Wegener's granulomatosis. We also discussed drug-induced vasculitis, and I want to remind you that the 3 drugs you should know which may cause vasculitis-like syndrome include minocycline, hydralazine, and propylthiouracil. We also discussed back pain and also spondyloarthropathies, and also included psoriatic arthritis and Lyme disease. So we'll continue from then onwards. So if you would show me the first slide, please. Okay, we'll start with a question. I'll read the question and you need to answer, and there is some form which will tell us how many of you answered which way. A 44-year-old married woman and a mother of 4, aged 3 to 8, is evaluated because of a 2-week history of aching in the joints of her wrist, plural, hands, plural, and knees, plural, symmetric. Pain and swelling were severe for a week and then subsided to aching. The pain is worse in the morning. Anytime anything is worse in the morning, that means after inactivity means inflammation, and abates with activity. On physical exam, there's a tenderness with pressure over the dorsa of the wrist. One side of her face shows a faint redness. Note that it is unilateral. She has noticed patchy sloughing of her skin in the hands. Next slide, please. Which is the most likely diagnosis? SLE, rheumatoid arthritis, disseminated GC infection, parvo B19, psoriatic arthritis. Please answer. Okay, I think half of you got 53% got the correct answer. The correct answer is parvo B19. I do not know why almost 1/3 of you said rheumatoid, and also somebody said psoriatic. So let's go over to the next slide, please. Parvo B19 is a common infection in the children, and in the children, it is called erythema infecciosa, or the 5th disease. The first 4 diseases are the exanthems, chickenpox, rubella, rubella, etc. This is the 5th disease. The interesting thing about why should we know this, even though it's a child's disease, because it affects adults also. And it's interesting that it affects the RBC precursors, the pro-normoblast in the bone marrow, leading to a transient aplastic crisis, particularly if the patient is undergoing hemolysis from other reason. So a person has a sickle cell disease, which is a chronic hemolytic state, and if they get parvo B19, the RBC multiplication will stop, and the person will have RBC aplasia, but not WBC, not platelet. In the adults, it causes acute symmetric polyarthritis, which may take 6 to 12 months to resolve and can be mistaken for RA. Why is that? Why most common misdiagnosis is RA? Because the distribution of the joints is same as RA, small joints of the hands, wrist, elbows, knees, and ankles. So if a young lady comes to you with those findings, you would tend to think rheumatoid arthritis. And if you do a rheumatoid factor may be positive even in a parvo B19 infection. Because after all, what is rheumatoid factor? A rheumatoid factor is an IgM against an IgG. And as you all know, the first antibody we make is IgM. So if you have a common cold, if you have an influenza, if you have pneumonia, your rheumatoid factor may be positive. Therefore, last week I said, do not make a diagnosis of rheumatoid based strictly on serology. The diagnosis of parvo B19 is due to IgM antibody of the parvo B19. But please remember that the window for IgM antibody is only about 3 to 4 weeks. So you have to catch the diagnosis early. If you miss that window, you will not have an IgM antibody. It will have an IgG antibody, which merely means that the patient had parvo B19, but you cannot tell why. There is no particular treatment except supportive treatment, NSAIDs, but it is a self-resolving condition. It's interesting to note that the child gets erythema infectiosum and the mother gets arthritis. It's interesting. And the person with the hemolysis would get aplastic anemia. Next slide, please. A 28-year-old woman is evaluated because of a 9-day history of arthritis, fever, and chills. These symptoms followed by pain and swelling of the second and the third MCP and the PIP joints on the right side, and a second, third, and fourth MCP joints on the left side. So it's bilateral, but it's not particularly symmetric. As the swelling of the joints resolved, the right wrist became swollen, warm, and painful. So immediately you can say that this is a migratory arthritis. The patient developed a mild sore throat. Her last menstrual period ended 6 days ago. She is a monogamous sexual relationship. Don't ever be fooled by that statement. She may be monogamous, but her partner may not be. On physical examination, her temperature is 101, heart rate is 100, blood pressure is normal. Her posterior pharynx is red. They told us earlier that the pharynx, the person had a sore throat. Her lungs are clear. A soft systolic murmur is audible around the left sternal border, and the rhythm is regular. When you read this question, you know what the examiner wants you to think. They're giving you sore throat, they're giving you joint pains, and they're giving you pharyngitis. So they want you to, and then they're giving you migratory arthritis. They want you to think that this is rheumatic fever, because we all knew in medical school that that's how rheumatic fever works. Let's see the next slide. There is a 5 mm vesicle surrounded by a red skin on the right forearm. There is tenderness along the extensor indicis tendon and flexion of the second MCP joint on the right. So now it is not joint, it is a tendon. And effusion is palpable in the right knee. Pelvic exam is normal and there is no cervical discharge. Which of the following is the best initial treatment for this patient? Codeine, ibuprofen, ceftriaxone, penicillin, prednisone. Please answer. Okay, I think 50 some percent answered correctly. The correct answer is ceftriaxone. I'm somewhat surprised that somebody wants to give codeine. Ibuprofen is okay, but the correct answer is ceftriaxone. So let's see the next slide. This is disseminated gonococcal infection, otherwise called arthritis dermatitis syndrome. And this is the triad, a triad of tenosynovitis, polyarthralgias, migratory, and dermatitis. This woman has tenosynovitis because her symptoms were not limited to the joints. She also had, along the tendon lines, inflammation. She had polyarticular onset, and it is typically migratory. Migratory means that it moves from one joint, joint A, to joint B, but A becomes normal and then goes to joint C, and B becomes normal. There are only two conditions in rheumatology which give you typical migratory arthritis. One is acute rheumatic fever, we learn in medical school, and second is disseminated GC. The risk factors for this is pregnancy because of the placenta being a vascular organ. It allows the organisms to enter the circulation, and menstruation because menstruation breaks the endometrium and allows the organisms to enter the circulation. Now note that they told you that her menstrual period ended 6 days ago. That was a clue. You get migratory arthritis, you get tenosynovitis, and you get dermatitis. Remember, she had a little vesicle on her forearm. If you do a synovial fluid analysis, most likely it will be culture negative. And treatment, of course, of gonococcal disease is synovitis. You're seeing the picture on the left is a little vesicle. Picture in the middle is just a little erythema. And picture on the right, of course, is the gonococcal urethritis, but you may not see that. And particularly in a woman, it is much more common, 9 times more common in women than men, because they have the predisposing factors of menstruation and or pregnancy. The men, though the incidence of gonococcus is same in men and women, arthritis dermatitis syndrome is almost exclusively a disease of women. Next slide, please. We are going to now rheumatoid arthritis. I'm showing you the hand at the bottom. It's a painting. You see the severe deformity, the muscle wasting, the swan neck deformities. Now, in today's age, we should never see this because we have treatment to prevent this. But we have, unfortunately, many patients in our community who have this. The picture on the top right is the rheumatoid synovium. It looks like a tumor, and that's what it's called pannus, and that's what erodes the bone. And picture on the left is the rheumatoid synovitis. Look at the number of lymphocytes, the number of cells in that thing, and they all literally chew up the bone and the cartilage. Next slide, please. So it is a erosive disease. The hallmark of persistent synovitis in patients, and the erosions occur within the 2 years of onset. So what you do not have when your patient enters your office with rheumatoid arthritis, what you do not have is time. Because if you delay treatment, erosive disease will occur. And disability occurs within 5 years in up to 50% of the patients. So this is a serious disease. And the good news is you can prevent it. Next slide, please. A 33-year-old woman is concerned about development of rheumatoid arthritis. She has a mild discomfort in the hands at the end of the day. She is a software engineer and smokes 5 cigarettes per day for the past 2 years. She drinks 1 glass of wine daily. Her identical twin has rheumatoid arthritis. Physical exam is normal. Her BMI is 32. Which of the following is the most appropriate preventive measure for this patient at the risk of developing RA? A, avoid food drinks containing high fructose corn syrup. B, begin probiotics. C, smoking cessation. And D, lose weight. Please answer. Okay, I think everybody got this right. I think losing weight is a good thing to do, but it has no impact on development of rheumatoid arthritis. We know all about smoking and what it does to the lungs and the heart and the vessels, but very little do we pay attention to regarding its impact on immune system and particularly rheumatoid arthritis. The answer A would be in what condition? I know we can't talk to each other, but that is gout. When we do gout, we will talk about the role of high fructose syrup. As far as I know, there is no role for probiotics in any rheumatological condition. Losing weight is always good, probably has some value in osteoarthritis, particularly of the knee, but otherwise no impact on rheumatoid arthritis. Next slide, please. Okay, let us talk about rheumatoid arthritis. Remember, in rheumatology, if you have hypertension, you have a equipment which tells you a blood pressure of 160/90 and you have a diagnosis. If you have myocardial infarction, you have Q waves, high troponins, you have diagnosis. In rheumatology, there is no such thing. because rheumatology consists of syndromes. Syndrome means, syn means together, drome means to run. When things run together, it is a syndrome. So for example, if you have arthritis, conjunctivitis, and urethritis, you call it writer syndrome or reactive arthritis. There is no diagnostic test, there is no imaging which will make the diagnosis except a history. So all rheumatology, every rheumatic disease has clinical criteria. Now, some of them also include laboratory criteria. So these are the criteria for rheumatoid arthritis. And they will ask you a question and answer would be, is this rheumatoid arthritis? The only way to answer, does that patient meet with any of these criteria? So I'd like to go over this. Morning stiffness lasting for at least 1 hour. Because a lot of people, particularly older people, are stiff in the morning for about 20 to 30 minutes. So they gave a 1 hour cutoff point. Swelling in 3 or more joints. Swelling of the small joints of the hand. Swelling which is symmetric. Erosions on or decalcification or osteopenia on x-rays. You should never reach that stage to make a diagnosis, but they put it in. Rheumatoid nodule and rheumatoid factor. The first four, the morning stiffness, 3 joints, hand joints, and symmetric joint involvement must be present for at least 6 weeks to make the diagnosis. If they are 3 weeks or 2 weeks, it can still be rheumatoid, but you should stay away from making the diagnosis, as I just showed you a few minutes ago with the Parvo B19. Parvo B19 infection would satisfy 1, 2, 3, and 4, but is not rheumatoid because it will go away after a while. So be careful about making the diagnosis. Next slide, please. Remember that viral infections can cause a short-lived inflammatory arthritis as Parvo. A negative rheumatoid factor does not exclude rheumatoid arthritis. If you take 100 patients with rheumatoid, 85% will have a positive rheumatoid factor, but 15% will be negative. We call them seronegative rheumatoid arthritis. A positive rheumatoid factor alone is not a diagnostic of RA. This is a common mistake made. For some reason, rheumatoid factor is done, rheumatoid factor is positive, and the doctor says you have rheumatoid arthritis. That is wrong. You need those criteria to be satisfied, and positive rheumatoid factor is only one of those 6. The other point to remember about rheumatoid factor, fluctuations of rheumatoid factor does not mirror, fluctuations do not mirror disease activity. So for example, if rheumatoid factor is positive in 1 in 320 dilution today, and tomorrow it is 640, it doesn't mean the disease is more active tomorrow than today. So serial testing is not indicated. Now, when we come to double-stranded DNA, that would be exactly the opposite. Next slide, please. So we do 2 antibodies, rheumatoid factor and anti-CCP. So what is its value? And I want you to understand this slide very carefully. I'm not going to go to the sensitivity and specificity of each. They are very similar. The important point is the last point in the red circle. If both of them are negative, there is a 96% probability that the person does not have rheumatoid arthritis. So it is like many rheumatological tests, it has a tremendous negative predictive value. So you do a rheumatoid, clinically you think patient has rheumatoid, you do a rheumatoid factor, you do anti-CCP antibody, both are negative, there's a 96% probability patient does not have rheumatoid arthritis. Next slide, please. This is a photograph, X-ray of a same patient over time, probably over a year and a half. If you take C, the picture on the right, you can clearly see the erosions. They are called marginal erosions. That's what you don't want any of your patients, because that's what causes deformity and destruction. Picture in the middle gives you, in retrospect, some suggestion that something was going on. Picture on the A is completely normal. Now, I remind you that MRI is not indicated. Choosing wisely, people do not want us to do MRI on small joints. Next slide, please. Rheumatoid arthritis in US, we call it rheumatoid arthritis. In Europe, but mostly in UK, they call it rheumatoid disease. And you know why? Because it causes all kinds of extra articular features. I just listed a bunch of them. C1, C2 subluxation is not extra articular, but it comes up in clinical practice. BOOP is a manifestation of rheumatoid arthritis. Vasculitis, typically a medium vessel vasculitis. Cricoarytenoid involvement. Cricoarytenoid joint is sitting near the vocal cords. It is a synovial joint. The person will have hoarseness, and if they have intubation, upon extubation, the airway may collapse. Kaplan syndrome, note the spelling of Kaplan is C, not K. Kaplan syndrome is a pneumoconiosis first, followed by rheumatoid arthritis later. You see it in coal miners. We don't see in New Jersey, but if you work in West Virginia or someplace, you will see that. Almost every patient with rheumatoid arthritis after some time will develop Sjogren's syndrome. They also develop pleural effusions, and pleural effusion is noted for its low glucose. They develop interstitial fibrosis involving the base. Last time I told you that all rheumatic diseases, dermatomyositis, polymyositis, lupus, scleroderma, rheumatoid arthritis, they may develop pulmonary fibrosis involving the base, including rheumatoid arthritis. There's one exception, and that is spondyloarthropathies. Spondyloarthropathies develop fibrosis at the apex. Felty syndrome, which is a chronic rheumatoid arthritis, neutropenia, and non-healing ulcers. Rheumatoid arthritis also may affect the sclera or the uveal tract. When a patient is on anti-TNF therapy, we will discuss that in a few minutes, that can invoke a heart failure in a compromised patient. So a rheumatoid patient can come up with any of these and many more I haven't listed. Next slide, please. This is a rheumatoid nodule. It occurs in the area of friction, therefore it is very common at the elbow, but it can occur in tendons. If a person is confined to bed, it can occur in the gluteal region as well as the occiput, and it can ulcerate. It may occur in internal organs. I'll show you some pictures in a minute. The interesting thing to remember is that methotrexate, though improves the joint, but it may enlarge the nodules. So that may be a question. Patient comes in with rheumatoid arthritis, you put them on methotrexate, they come back in 6 to 8 weeks, the arthritis is better, C-reactive protein is down, saturate is down, but the nodules are bigger. What is the cause? It is methotrexate. Why it happens? We don't know. Next slide, please. A 57-year-old man with rheumatoid arthritis comes for a routine evaluation. He has no major concerns or complaints and is a lifelong non-smoker. Medications are prednisone. There is a role for prednisone in rheumatoid arthritis. We'll talk about this when we talk treatment. An NSAID, naproxen 500 milligrams twice a day, methotrexate 20 milligrams every week by mouth, and infliximab, a tumor necrosis factor inhibitor, 300 milligrams every 8 weeks. On physical, so he is on a very nice cocktail. On physical exam, his pulse rate is 88 and blood pressure is 130/80. BMI is 27, is overweight. He has a hand deformities consistent with rheumatoid and some synovial swelling. So in spite of all this, he seems to be still having activity. Next slide, please. Which of the following is the most likely cause for a premature death in this patient? Please remember that patients with rheumatoid arthritis die younger than usual. There's a common misbelief among people and among doctors even that people with arthritis don't die. They do. They die prematurely. So the answer for you is cardiovascular disease, infection, peptic ulcer disease, rheumatoid arthritis itself, or pulmonary embolism. What is the cause of death, premature death, in patients with rheumatoid arthritis? Please answer. Okay, very good. I think almost all of you got things. Um, if I had asked this question 20 years ago, probably infection would have been the correct answer. But this is a relatively new knowledge. New means about 15 years old. Patients with inflammatory conditions, connective tissue disease related, lupus, rheumatoid arthritis, scleroderma, and others. Those patients have premature and accelerated atherosclerosis. There are many theories why. I think the most plausible theory is that they have a subclinical vasculitis, endothelial dysfunction. So, what is the message? What is the learning point for you're taking care of a patient with a rheumatoid? Patient is fine, arthritis is under control. Would you change the management? The management change would occur as follows. You would aggressively go after the risk factors because consider that patient as a coronary equivalent. Remember with diabetics, we do that. If you have a diabetic but nothing else, we ought to still treat them aggressively, lower the lipids, treat their blood pressure, maybe give them an aspirin. I think we should do the same thing for rheumatoid and lupus and other connective tissue patients. Aggressively go after them, make them stop smoking, have them lose weight, uh, check their blood pressure and keep it under proper control. If they're diabetics, get their A1C down and others. But cardiovascular disease has become a major problem for patients with rheumatoid arthritis. Next slide, please. After 10 years of disease activity, please note this, after 10 years of disease activity, 50% of patients will have cervical spine involvement, but they may not be symptomatic. But if you take their x-ray, they may have problems. So when you clear a patient, we internists clear these people for surgery. So a patient walks in your office typically on a Friday afternoon, going for surgery on a Monday morning, gallbladder removal, and they want a clearance. You have to assume if the patient has rheumatoid for 10 years, that patient probably has cervical spine involvement. They may not have symptoms, or they may have occipital headaches, they may have paresthesia, neurological compromise, or even paralysis. So what should you do before surgery? Number one, you should diagnose that. So next slide, please. No, go back, please. I'm sorry. I will answer the question. So before surgery, you need to do two things on every rheumatoid patient. You should ask, do they have cervical spine involvement? The answer would be by symptoms, but they may not have symptoms. Therefore, you do an X-ray. And the exams, they always ask you X-ray in flexion and extension. You have to take two views of cervical spine to determine atlantoaxial problem. And if they have a disease, you should work with the anesthesia person and consider nasal intubation, nasal rather than regular intubation. Because if they have the atlantoaxial subluxation and they go under anesthesia in a routine manner, they may impinge the spinal cord, and when they wake up from anesthesia, they may be quadruparetic. I have seen one case which I'll never forget, and therefore this precaution is essential. The other precaution for surgery for rheumatoid patients is the involvement of the cricoarytenoid joint. Cricoarytenoid joint sits next to the vocal cords. The synovial joints can get inflamed, and the symptom for that is hoarseness and recurrent sore throats. So these patients typically keep getting antibiotics after antibiotics. If that patient shows up in your office for medical clearance for tomorrow, please don't. Send them to an ENT person who should do a laryngoscopy and see the movement of the vocal cords. If they have abnormalities, they should not go for surgery because if they do, upon extubation, their airway will collapse. It's a disaster in the recovery room. So if you find it, treat them with steroids for a few days, postpone the surgery, and alert the anesthetist that upon extubation, the person should be watched. I've seen that once also. Next slide, please. Lung is a big target for patients with rheumatoid arthritis. As we discussed, they can get pulmonary nodules. So if they give you a patient with rheumatoid arthritis of 10 years, and a chest x-ray for some reason shows a couple of nodules, please do not assume that these are rheumatoid nodules. They may be cancer, they may be metastasis. So the workup for those nodules is the same as any other. They get pulmonary fibrosis, basal, Kaplan syndrome, if they work in a coal mines. The sequence of Kaplan syndrome is pneumoconiosis first after 20 years working in the coal mines. Then there is an accelerated fibrosis for about 1 or 2 years. And then the person develops rheumatoid arthritis. It's a very elegant syndrome described by Kaplan from England in the coal mines. And Kaplan was a radiologist, never saw a patient, but he saw the x-rays. And he developed an expertise by looking at an x-ray, he would tell this patient would develop rheumatoid arthritis in 2012 or 2014. He developed that kind of expertise. We don't see it in New Jersey, but if you go into some states, you will see that. BOOP is another manifestation of rheumatoid. We talked about pleural effusion. Characteristic of that is low glucose. I talked to you about cryoretinoiditis, giving you hoarseness and collapse of the airway. Remember that Wagner's granulomatosis and polychondritis, relapsing polychondritis, are two other conditions which give you collapse of the upper airway. We talked about that last week. And of course, methotrexate can cause lung fibrosis also. Very hard to distinguish from rheumatoid arthritis. Next slide, please. This is a patient, if you look at it, you will think that this is metastatic disease. Actually, it happens to be rheumatoid nodules, big, large nodules. But your workup for this patient is going to be same, even when you know that the patient has rheumatoid arthritis. You cannot assume these are rheumatoid nodules. Next slide, please. This is a patient with Felty syndrome. The classic Felty syndrome is neutropenia. Note that in lupus, they get lymphopenia. In Felty syndrome, they get neutropenia. So it is rheumatoid arthritis for many years, like 20 years, splenomegaly, neutropenia, and non-healing ulcer. This is what Felty described. But we don't see that nowadays. We see wound dehiscence as a marker for non-healing ulcers. So for example, the classic question will be, a patient has rheumatoid arthritis for 20 years, goes for a knee replacement, doing well. However, on the 10th postoperative day, his wound dehisces. And they will give you a white count of 3,900. They will not tell you anything about the spleen, but they will tell you patient has a rheumatoid arthritis for 20 years. What's the diagnosis? That is Felty syndrome. And the picture on the left is the spleen. Picture in the middle is the dehiscence of an abdominal wound, any wound. It doesn't have to be knee arthroplasty. And the photo on the right is the non-healing ulcers of the leg. So I'm sure you have wound care clinics in your place. If you see non-healing ulcers, keep in mind that there may be something immunological like Felty syndrome. Next slide, please. This is a classic Felty ulcer. Next slide, please. Okay, we are going to talk about the management and treatment of rheumatoid arthritis now. Of course, the first thing we give them, anybody with inflammatory arthritis, is non-steroidals. But please note that non-steroidals have practically no effect on the disease process. They will reduce inflammation, they will reduce pain, but they will not reduce the progression. Remember what we are trying to do in rheumatoid arthritis is to prevent the erosive disease so it doesn't eat up the bone. NSAIDs do not do that. Now, when we talked last week of spondyloarthritis, NSAIDs have a large role in spondyloarthritis. If NSAIDs work, you don't have to go to biologicals, but not in rheumatoid. The exams typically ask either ABIM boards or MOCs or recertification side effects of NSAIDs. So you must know every side effect of NSAID there is. The commonly missed side effects, I'm not going to go through this because it will take a long time, but the most common missed side effect is GI. Everyone knows about peptic ulcer and bleeding, but there are two I want you to particularly remember. One is it causes a diaphragmatic lesions in the ileum and causes bowel obstruction due to NSAIDs. And second, microscopic colitis has been linked with NSAIDs. So they are not going to ask us peptic ulcer or bleeding. Everybody knows that, but they will ask you the others. Next slide, please. There are a bunch of disease-modifying agents. They are called DMARDs, hydroxychloroquine, sulfasalazine, cyclosporin, we don't use much, azathioprine, D-penicillin, and gold are not used. I like those drugs because I'm old enough to know that they were very popular once upon a time, particularly gold. It's not even available. But the most favorite drug now is methotrexate. And we use leflunomide only if methotrexate does not work or cause some sort of a intolerance. Next slide, please. Next slide, please. I'm just going to give you the highlights. This is a retina of a patient who is on hydroxychloroquine. Hydroxychloroquine is, in my mind, a very benign drug, very useful. You can use for rheumatoid, you can use for lupus. Effective and relatively, I would say, safe overall. But there is one side effect which can be devastating, and that is blindness. It is called pigment retinopathy. As you can see on the picture on the left, there is a bullseye lesion, there is a central area of darkening, there's a halo around it, and then there's another darkened circle. This person is blind. Picture on the right is early. It's in the macula. You can see the pigment deposits. No one on hydroxychloroquine should ever go to this level. So if you give hydroxychloroquine, which is an easy drug to use, and it is meant for internists, not for rheumatologists. As an internist, one can use them. You must send your patients to an ophthalmologist on a regular basis. The newer technique for the ophthalmologist, everybody doesn't do it, is the optical coherence study, some sort of a scan where they can look at every layer of the retina and detect the side effect early. The incidence is not very high, it is very small. I have seen maybe a couple of cases in my life, but it's a wonderful drug, hydroxychloroquine. The side effect, which almost everyone gets, is diarrhea in the first week. So when you start hydroxychloroquine, the dose is 200 milligrams twice a day. Tell them to start with 1 tablet a day and then gradually build it up. It's like metformin. You don't want to scare them by giving them 2 tablets a day on day 1. Next slide, please.
Dr. Kothari, would you please repeat the side effects of the NSAIDs again?
Well, the only side effects I wanted to mention was in the gastrointestinal tract. You have diaphragmatic lesion in the ileum, which causes bowel obstruction. There are little diaphragms with little holes in it through which stool passes. And the other one is NSAIDs have been linked to microscopic colitis. It's not certain, but it is, gastroenterologists always take you off NSAIDs if you are on NSAIDs and you have chronic diarrhea. So let's take this. A 71-year-old woman is evaluated for burning sensation on her feet. Burning sensation means neuropathy, which is worse at night. There is no back pain, muscle weakness, bladder or bowel dysfunction. She has a rheumatoid arthritis for the past 3 years. And her medications include hydroxychloroquine, which we just talked about, low-dose prednisone. The definition of low-dose prednisone is prednisone dose below what we make every day. You and I make 37.5 milligrams of hydrocortisone every day on an average, which is a 7.5 milligrams of prednisone. So if you take prednisone below 7.5, it is considered low dose. Anything above is not low dose. And leflunomide, which is a parallel drug to methotrexate. Vital signs are normal. There is a decreased sensation to light touch and vibration is limited to her feet, plural, feet, both feet. Her MCV joints are mildly swollen and tender. Muscle strength and reflexes are normal. CBC, creatinine, and glucose are normal. So here is a 71-year-old woman who is on these 3 drugs and has a developing neuropathy. Which of the following is the most appropriate step? Begin gabapentin, increase prednisone, stop leflunomide, and stop hydroxychloroquine. Next slide, please. Just answer the question. A woman with rheumatoid arthritis and a neuropathy, what is the cause? Which drug? Good. I think many of you answered. Somebody said start gabapentin. I think the generic principle is that if you have a insult from a drug, do not give another drug until you stop the medicine. If you follow that principle, then adding gabapentin would work, would give us some relief, but that is not the idea. Nobody did increase prednisone. Someone says, few people said, stop hydroxychloroquine. Hydroxychloroquine does not do neuropathy, does not cause neuropathy, but leflunomide is known to do so. I don't remember the percentage, so the answer would be discontinue leflunomide, wait for a while, and then rethink the treatment. Let's talk about tumor necrosis factor alpha inhibitor. I'm not going to go through the extensive list of all the biologicals available. That can take a day, but I just will give you some general idea about what these things are. The first one in this series was etanercept, Enbrel, is a TNF receptor Fc fusion protein. Basically blocks TNF, tumor necrosis factor. Infliximab is a chimeric protein. Chimeric means a little bit of mouse in it. So you make antibodies and the efficacy goes down. And the adalimumab is a recombinant monoclonal anti-TNF antibody. Therefore, there is no foreign protein in it. It's human. That's why the adalimumab has become very popular. Next slide, please. And there are a whole bunch of other biologics. We don't have time to go in, but I'll just give you generic side effects of this. Of course, local injections, but the most important thing we would need to worry about is certain infections, particularly tuberculosis. It doesn't have to be TB, it could be fungal, but TB is the one we worry about. There have been case reports of a demyelinating disease such as multiple sclerosis in these patients. They all cause bone marrow suppression, so you have to check CBCs. I think the question mark should be removed. I think there are now cases where you do develop lymphomas. And remember, many times our patients are very young, 20, 30 years of age. Disease is chronic, and you commit them to a tumor necrosis factor inhibitor. What happens when she is 40 or 50? Something to consider. Because there is a foreign protein, they may develop antibodies and the efficacy may go down. Tumor necrosis factor inhibitors are an absolute contraindication to heart failure. So you have to make sure that the patient doesn't have an underlying heart disease. This is a new class of drugs which may cause a positive ANA without symptoms or pure lupus-like syndrome. And do not combine 2 biologicals. Next slide, please. Just want to emphasize that this is the same patient. The patient on left and patient on right is the same woman. Why this so much difference? Because she was on corticosteroids. This is what cortisone does to people. Now, I think all of you have seen this. Terribly Cushingoid, a beautiful woman converted into pretty bad appearing face, moon face, etc. And this is only outside. If I tell my patients that if I tell you all the side effects of cortisone, you will never talk to me. So what is the role of cortisone, prednisone in rheumatoid arthritis? Next slide, please. So let me just give you the algorithm, and then I will tell you the role of steroids. When I was a resident and when I was a fellow, um, most of you would not know this, the treatment of rheumatoid arthritis was called the pyramidal approach. And the pyramid had a big base. The base consisted of education, physical therapy, diet, nutrition, etc. And then as you advance on the top of the pyramid, you started to use NSAIDs for a couple of years. Now remember I told you a few minutes ago that the erosions occur in 2 years. So already erosions have taken place. Disability in 50% occurs in 5 years. And I told you that one thing you do not have in treating rheumatoid arthritis is time. So you don't go every couple of months or couple of years a change. So this is what it is. This is the most current guideline. You diagnose synovitis, you make sure it is rheumatoid arthritis and not parvo or something else. Immediately start oral methotrexate. Methotrexate is called low-dose methotrexate therapy because in cancer, you use methotrexate around 50 to 100 milligrams a week. In rheumatoid arthritis, you use 7.5 to maximum 25 milligrams a week. If you use methotrexate by mouth and you reach certain number, we'll talk about that, and the response is not adequate, you switch it to parenteral methotrexate. Do not jump into biologicals. Use methotrexate to its maximum capacity. Subcutaneous injection every week. If the response is not there in a couple of months, we are all talking about few months, you can add sulfasalazine, hydroxychloroquine, or loflunomide. If that doesn't work, we are now in the month number 4 or 5, 4 probably, you use a biological, etanercept. If etanercept doesn't work, why etanercept? That was the first one and probably cheapest in the market. You can use Humira, you can use infliximab, you can use some newer ones. If that doesn't respond, change the biological. The point here is you have to be early, aggressive, and be willing to make very rapid changes in your management. And the person eventually will end up receiving methotrexate, a biological, probably an NSAID just for relief. So where is prednisone in this? You note that there is no prednisone here. Now the problem with this algorithm is methotrexate will take 6 to 12 weeks to work. Patient is in pain in front of you. So what do? She is not going to wait for 6 to 12 weeks, or she may wait, she has no choice. So what do? You give low-dose prednisone as a bridge. But you make a pact with the patient because prednisone effect is so powerful that the patient will be very reluctant to get off. So you have to tell the patient upfront that I'm not going to give you this after 8 weeks, whatever time you choose, because otherwise it will be impossible to get the patient off prednisone. And you're dealing with mostly women, young women, and you put them on prednisone, you will have a disaster in a few years. Next slide, please. A 65-year-old woman has a seropositive rheumatoid arthritis for 1 year. That means rheumatoid factor positive. Note that higher the titer, worse the prognosis. So rheumatoid factors value is not only diagnosis, but also prognosis. She's taking methotrexate 17.5 milligram weekly for the past 6 months. In addition, she's on prednisone 5 milligrams and NSAID PRN. She reports significant improvement since she started methotrexate, but still has 45 minutes of morning stiffness, which is bad. A morning stiffness, the amount is a poor man's SAD rate and a few painful joints. So she had a response, but not really what you want. She has a mild nausea after taking methotrexate. She's taking 17.5 milligrams, which is a good dose. Vital signs are normal. Examination is unremarkable except for 4 tender, swollen joints. The 4 of them, tender and swollen. Rheumatologists love to count joints. So there are 4. The calculated DAS28 is 4.2. I'll explain to you because they have introduced this in the MOC. So I expect that it will come in your boards too. The DAS22 is 4.2. Hematocrit is little low. ESR is 22, which is not bad. Next slide, please. So let me just go over the DAS28. The DAS28 is a calculation where you add global health parameter. 100 would be maximal disease activity. You count the number of tender joints and you count the number of swollen joints. I told you rheumatologists like to count joints. And then you all enter that into a computer and it spits out the DAS28, and you can also add ESR. Next slide, please. If the DAS28 ESR is less than 2.5, it is remission. If it is 5.1, it is high activity. Now, can you please go back a couple of slides to the text of the question? Okay, here it is. The calculated DAS is 4.2. So go forward. Next slide, next slide. So look at 4.2. What tells you that the person has moderate rheumatoid activity in spite of the treatments he's getting? Next slide. Which of the following is the next step? Remember, she was on methotrexate 17.5 milligrams. So increase the dose of oral methotrexate, add hydroxychloroquine, add sulfasalazine, add tumor necrosis alpha blocker, and use subcutaneous methotrexate. Please answer. Okay, I think this requires a discussion. The 1/4 of you said increase the oral dose of methotrexate. Now, remember that they told you she had a nausea. So if you give her more oral methotrexate, she is going to throw up. And hydroxychloroquine and sulfasalazine may have some effect. But the principle here is that you should use a drug to the fullest maximum. Have we used methotrexate to its full effect? The dose of methotrexate is 25 milligrams maximum. She's on 17.5. But the problem is, if you use more by mouth as the first answer, she's not going to be able to tolerate. The other thing is, after 15, the bioavailability of methotrexate goes down if it's given by mouth. So even 17.5 should not have been given. After 15, the gut does not absorb methotrexate, but will give you side effects. So the correct answer is use subcutaneous methotrexate. It's an injection every week. You can go up to 25. Typically what I do, and I'm sure my fellow rheumatologists do, after 15, we switch them to subcutaneous injections, fairly straightforward. Diabetics do this every day. They take one injection a week and they can go up to 25. And the effects are fantastic. They're very good. I am personally very happy with this treatment. And if I do this and the patient succeeds, I can avoid D, tumor necrosis factor blocker. It's cheap, a few dollars versus a few $1,000s. Besides, all the side effects of tumor necrosis factor blocker, including lymphoma, are removed. So the learning point in this question is learn how to use methotrexate, learn the dose of methotrexate. There are very few questions in the board that are related to dose. This is one of them. And also remember that subcutaneous injection is available in methotrexate. I like this question because I think many of us don't do this. We just jump to biologicals. Next slide, please. So summary of rheumatoid arthritis. Know the criteria for diagnosis. Once again, there are clinical criteria with some laboratory. Diagnosis should never be made on the basis of a positive rheumatoid factor. Know the value of rheumatoid factor and anti-CCP antibody. Both are negative. There is 96% probability that the patient does not have rheumatoid arthritis. Know that the treatment is early and aggressive. Prevent and treat osteoporosis and vascular disease. I told you it's almost like a coronary equivalent. Screen for osteoporosis. All patients should be on vitamin D and calcium and vaccinate. I think that is all of us know this. So that is the brief summary. We'll move to the next slide. Some more points. Methotrexate and leflunomide are absolutely contraindicated in pregnancy. Hydroxychloroquine and sulfasalazine can be used during pregnancy. All patients undergoing general anesthesia should have a cervical spine X-ray in flexion and extension to assess for atlantoaxial subluxation. Next, please. So let's try this. A 40-year-old woman has a 4-week history of low-grade fever, fatigue, and weight loss. Some constitutional symptoms. She has 5-year history of rheumatoid arthritis that is well controlled with diclofenac, which is an NSAID, methotrexate, and for the past 18 months, etanercept. So she is on the whole cocktail. She discontinued prednisone 8 months ago. That's a good news, and continues to have marked improvement in her joint symptoms. So note the dichotomy here. Her joints are better, but constitutionally, she's not well. Physical exam is normal. Blood count shows normochromic, normocytic anemia. Worse, her baseline inflammatory anemia. So there's something going on here, and leukocyte and platelet counts are slightly decreased. Remember, she's also on methotrexate, so it is likely that those counts may go down. Intermenstrual urine analysis is normal, except for RBC count of 100 plus. They did intermenstrual because they didn't want to have a contaminated sample from menstrual bleed. So this is true microscopic hematuria. So here's a woman who is on a bunch of drugs for rheumatoid arthritis, who now has fever and fatigue and weight loss, but the joints are much better. Next slide, please. Which of the following is the most likely diagnosis? Urinary tract infection with MTB, subclinical nephrolithiasis, carcinoma of the bladder, and interstitial nephritis. Please answer. Okay, I think this requires question. The correct answer is urinary tract infection with Mycobacterium tuberculosis. Only 15% of you answered that. Carcinoma of the bladder, I think you were mistaking these for cyclophosphamide. That's why you probably answered that. Interstitial nephritis requires much more than that. This is not something occurs over a long time. Your urine analysis should have white blood cells, not RBCs. So what is happening here? People on biologicals, as this woman was, are prone to developing infections, particularly mycobacterial. That's the first thing, That's why we always do a PPD before we start these drugs. Second, 50% of those tubercular infections are extrapulmonary. That is your main learning point for this case. They're extrapulmonary, so they can pop up in the bladder, they can pop up in the intestine, etc. And here, this woman was on good profile drugs for rheumatoid arthritis. Her joints are improved, but she is not improved. And she has microscopic hematuria, which can be the sole manifestation of TB of the bladder. So that's what it is. Next slide, please. We are going into adult Still's disease. Very favorite topic for any issues in MOC as well as board exam. High spiking fever. Now, note the word high and spike. This is not the spike they report in morning report, 99 and 100. We are talking about 105 degree Fahrenheit temperature and next morning 97. That's a spike. So these patients typically have spiking fever. They can have arthralgias, but not predominant. They can have a rash. The rash is described as evanescent rash. If you see the word evanescent, Usually that's what they mean. That means that it is there and that goes away. Typically appears at the height of the fever. In children, when they get the Still's disease, the pediatricians will take the baby and put them in a bath, warm bath, and the rash will appear. Adults, of course, you can't do that. They can have general lymphadenopathy. That's why it is mistaken for leukemia. They can have pleurisy or pericarditis. They can have sore throat. They have a leukocytosis, including leukemia reaction. And the hallmark is they do not have rheumatoid factor or ANA. The clue to this disease is a very high ferritin levels. There are other conditions which can cause high ferritin levels, including COVID now, but this people ferritin is through the sky. And the treatment of this condition include NSAIDs, occasionally steroids, methotrexate, biologics. One of the worst complications for this disease is called hemophagocytic syndrome. It is a condition with fevers, splenomegaly, cytopenias, elevated ferritins, and evidence of hemophagocytosis in the bone marrow. You look at the cells eating their own cells, basically, that's what it means. Next slide, please. We are going to go through certain distinct entities now. Familial Mediterranean fever pops up in your mark as well as in your exam all the time. It's more common in Sephardic Jews and Armenians. That's the ethnicity. It causes recurrent fever, recurrent serositis, and recurrent arthritis. And if that continues for 5 to 6 years, person develops amyloidosis. And that would lead to nephrotic syndrome. The interesting thing about this and fascinating thing about this, that a 0.6 milligram of colchicine will prevent all of it. Corticosteroids are completely ineffective. Before we knew about colchicine, this disease was uniformly fatal. In kids 6 years old get this, at 12 years they got amyloidosis. By the time they're 18, they would get end-stage renal disease and die. We do see familial Mediterranean fever in this country. Next slide, please. Acute rheumatic fever. I think you should know the major criteria and the minor criteria. The major are pancarditis, that means endocarditis, myocarditis, pericarditis, all of them or one of them. Migratory polyarthritis, we already talked about gonococcal disseminated infection giving you migratory polyarthritis. This is another one. Sydenham's chorea, erythema marginatum. Most of my students, when I ask, they say erythema nodosum. It is not nodosum, it's erythema marginatum, and subcutaneous nodules. So the photograph on the left is a subcutaneous nodule. They are smaller than rheumatoid nodules. That's the biopsy, which shows an ASHOP nodules. The next slide is erythema marginatum. The next to that is erythema nodosum. And the last one on your right is a mitral valve, which has been completely sclerosed. And the picture on the left is the dance, the rheumatic chorea. Next slide, please. So what do you need to diagnose? You need 2 major, 1 minor, or 1 minor, 2 major, plus recent evidence of streptococcal infection. That is the most important thing. If you do not have evidence of streptococcal infection, such as positive culture, rising ASO titer, or recent scarlet fever, you cannot diagnose rheumatic fever. You can suspect, but cannot diagnose. And this is where the trick question came when I sat for my boards. They ask a question, a 19-year-old girl comes with fever, pericarditis, arthritis, and rash. What's the diagnosis? She had criteria for rheumatic fever, but it turned out to be, and she had chorea. She actually had lupus. So lupus can mimic that because rheumatic chorea and carditis never occur together. Never occur together. So keep this in mind. There's a question built into this. Next slide, please. We are going to go into lupus now. You can see the picture, there's a wolf, and the word lupus means wolf. And you can see the poor fellow whose face is all eaten up by lupus disease. That's why the name lupus comes from. Next slide, please. As I told you earlier, in rheumatology, we have criteria to diagnose, and I will mention some of these criteria in details, but you have a butterfly rash, a discoid rash, photosensitivity, oral ulcers, arthritis, serositis, pleurisy and pericarditis, that means neurological disorders, kidney disorders, hematological, immunological, and positive ANA. Note that majority of them are clinical at the bedside. Only hematological, probably kidney, immunological, and ANA are part of it. So the first learning point is that you should not diagnose lupus just because the ANA is positive. To make a diagnosis, next slide, please, you need 4 criteria present, either now or over time. So let's answer this question first. A 58-year-old man is evaluated for a 3-month history of fatigue and non-pruritic rash on the chest and arms. The rash worsens with sun exposure. The patient reports no pleurisy, dryness of the eyes or mouth, arthritis or Raynaud's phenomena. On physical exam, vital signs are normal. Skin, there is no other, on cutaneous exam, there is no other rash, alopecia, or oral ulcers. I'm sorry, I think there's a typo here. There is a rash. The appearance of the rash is shown. Next slide, please. And this is the rash. It's pretty significant rash on the trunk, on the arms, all the way to forearms. And the question is, next slide. Lab study shows metabolic panel, CBC, and urine are normal. ANA is negative. However, anti-Rho SSA antibody test result is positive. Which of the following is the most likely diagnosis? Livedo reticularis, Lyme disease, subacute cutaneous lupus erythematosus, or systemic lupus erythematosus? Please answer. Okay, I think most of you got this. This is a tough question. Let's get rid of the last thing, systemic lupus. Does it have any criteria for systemic lupus? No. ANA is negative, but another antibody is positive. So let me just walk you through this particular condition. A lot of people have difficulty with this disease. Subacute cutaneous lupus erythematosus. It's a sort of a misnomer. Before I go there, the picture on the left is livedo reticularis, which implies small vessel sluggish circulation. Can be small vessel vasculitis, person can be in extreme cold, can be atherombolism. We talked about this last time. The same thing on the second picture. The picture on the right, on the top, is the classic butterfly rash. And the picture in the bottom is the erythema migrans. We talked about that last week also. Next slide, please. The cutaneous subcutaneous, the chronic or subacute chronic lupus is a non-fixed, non-scarring, symmetric, widespread and superficial rash over a sun-exposed area. Frequently, the patients are on hydrochlorothiazide. Remember, one of the side effects of hydrochlorothiazide is photosensitization. So if they are on hydrochlorothiazide and any rash, take them off hydrochlorothiazide. It primarily affects Caucasian women. It may mimic psoriasis. The most common misdiagnosis is psoriasis or lichen planus. Even dermatologists make this mistake. The clue is associated with anti-Rho or anti-La antibodies. It is not necessarily lupus because the ANA may be negative, but it is classified under the lupus subheading. Next slide, please. If you see the picture on the left, there is a significant amount of deformity. If you take the 5th finger, there is a flexion of the distal joint, hyperextension of the proximal joint. You look at the 3rd finger, the same thing. Now, the interesting thing is that the X-ray is completely normal. There is no erosion, there is nothing. So I want to introduce 2 terms here. The picture on the left is called deforming arthritis because it's deforming. You can see it. The picture on the right does not show any bone erosion, therefore, it is non-destructive. So when rheumatologists say deforming, they mean clinical deformity, like on the left. When the rheumatologists say destructive, they mean erosions. So here is a patient who has a deforming arthritis, but no destruction. This is called JACCOD, J-A-C-C-O-U-D, JACCOD arthritis. It's a classic form of lupus. And lupus does not cause erosions. That's the whole point. But can cause shortening of the tendons and therefore the deformities. So if these hands are in your hands, you can play with them. You can take that fifth finger and straighten it out. But as soon as you straighten out the distal joint, the proximal joint will go the other way because you're dealing with a short tendon and a long finger. That's called Jacob's arthropathy. Next slide. Once again, lupus patients are very prone to developing cardiovascular disease. They have premature and accelerated atherosclerosis. They may have pericarditis, which is not silent, unlike rheumatoid. Rheumatoid pericarditis is silent. This is painful. They can get myocarditis. They can get conduction abnormalities. Conduction abnormalities are typically, they occur in a baby who is developing in a mother who has lupus, congenital heart block. And they can also get valvular disease, mitral and aortic valve. They have vegetations. That is called Liebman-Schack endocarditis. They are not infectious, but they behave as though it is an infectious bacterial endocarditis. Next slide, please. Lupus and lung. The primary effect on the lupus in the lung is the pleurisy, pleuritic chest pain. They can get effusions, but unlike rheumatoid, the glucose is normal. They can get interstitial lung disease involving the base. There are some case reports of acute lupus pneumonitis. They complete whiteout of the lung. They can get pulmonary alveolar hemorrhage, and they also may have shrinking lung syndrome, which is now being recognized more and more frequently, shrinking lung syndrome. So if you show me the next slide. Next slide, please. The shrinking lung syndrome, I thought there was a slide, but shrinking lung syndrome is a dysfunction of a diaphragm. It's a myopathy. It's a restrictive thoracic movement, and there is no treatment. This question comes up many times. What about pregnancy and lupus? So these are the things you should know.
Dr. Kothari, I had a question. It's Jonathan Shamash. Good evening.
Hi, John.
Quick question. When you showed that slide about cardiovascular effects a couple slides ago,
yes,
I assume that related to SLE as a whole and not to Jacquard's arthropathy. Is that correct?
The cardiovascular and Jacquard's are two separate things.
That's what I thought. So the cardiovascular side effects were really related to lupus as a whole, correct?
Correct. Yes.
Okay.
Yes.
Thank you for clarifying.
Sure. I didn't know we can ask questions. This would be nice to talk. Okay. SLE and pregnancy. It's a few things to remember. SLE does not interfere with conceptions. That's the first thing. Because people will come and ask you that. But there's an increased rate of spontaneous abortions, prematurity, and intrauterine deaths. The problem with SLE is that you cannot predict what will happen during pregnancy. 1/3 will flare, 1/3 gets better, and 1/3
does not interfere with conception, period. New line. There are increased rates of spontaneous abortions, comma, prematurity, comma, and intrauterine death, period. New line. SLE may flare, comma, get better, comma, or show no change.
Now, the important contrast is the rheumatoid arthritis. Almost 100% of women with RA, when they get pregnant, they get better. So why this is, we don't know. And that observation by Hench at Mayo Clinic led to the discovery of prednisone, cortisone. He got Nobel Prize for that in 1953. The key question is asked all the time, okay, you have a patient with lupus. Can she get pregnant? Yes, but the caveat is the disease must be controlled for 6 months. before conception. It used to be 2 years. We used to tell women 2 years your disease is quiet, then you can get pregnant. Now that fortunately that has been rolled down to 6 months. So this is a good news for women who wants to get pregnant. Next slide, please.
Dr. Kothari, can you please repeat the lung syndrome again?
The shrinking lung syndrome is a disease with chronic lupus where the chief complaint is shortness of breath, and you do the routine pulmonary function, you will not find anything. There may be a restrictive pattern on pulmonary function, and the etiology appears to be dysfunction of the diaphragms. It's a sort of a myopathy involving the diaphragmatic muscles. That's all we know about. But it is a distinct syndrome, rare, but it is there. Continue with the pregnancy and SLE. Prednisone is metabolized by placenta and therefore has a minimal fetal exposure. Azathioprine can be continued during pregnancy. There have been studies which shows that it does not affect the baby. Do not use NSAIDs if possible because it closes the patent ductus. You remember that a child is born with a patent ductus arteriosus, they give indomethacin or ibuprofen to close the duct. So you do not want to give pregnant woman NSAIDs, particularly in the third trimester, because it might cause premature closure. Patients with antiphospholipid antibodies syndrome should be switched to heparin and low-dose aspirin. Note that they have to have syndrome, and we discussed that last week. Next, please. This is the neonatal outcome of congenital heart block on the EKG, and you look at the baby. The baby has a rash, and that rash will go away in 6 weeks because the maternal antibodies have a half-life of about 3 to 4 weeks. Therefore, that baby will not have rash after 6 weeks, but the heart block will continue and the baby may need a pacemaker, will need a pacemaker. Next slide, please. A 21-year-old woman is evaluated for 6 months history of progressive fatigue, anorexia, symmetrical small and large joints arthralgias, and diffuse myalgias, accompanied by persistent rash over the face, neck, and arms. She also has acne vulgaris, treated with minocycline. Her only other medication is oral contraceptive. So she takes contraceptives, she's on minocycline, and she has this 6 months history of joints pain plus some constitutional symptoms. A diffuse confluent erythematous macular rash is present on the face and volar aspect of the forearm with no signs of scaling. She has no fever and she is normotensive. Next slide, please. On musculoskeletal examination, there is a symmetrical synovitis involving the proximal interphalangeal joints and the MCP, small joints. White count is low, ESR is high, not very high, but high. CRP is up. Rheumatoid factor is up, positive. ALT and AST are elevated. Anti-nuclear antibody is 1 in 320. Anti-CCP is negative. SM is negative. SM stands for Smith, not smooth muscle. Anti-double-stranded DNA is negative. Hepatitis B is negative, and hepatitis C is negative. Next slide, please. Which of one of the following is the most likely diagnosis? Psoriatic arthritis, hepatitis B-associated arthritis, minocycline-induced lupus, adult onset Still's disease. Please answer. Okay, everybody got it? This is a very good news. I think some of you thought adult onset, we just talked about adult onset Still's disease, hepatitis B. Okay, let me just walk you through this. This is a correct answer is C, minocycline-induced lupus. Next slide, let me see whether that, okay. It develops typically after 18 months of exposure to minocycline. And as you all know, minocycline is used commonly for acne. This is a young lady who is using minocycline for a number of years or months. It typically causes polyarthralgias and polymyalgias. It may have constitutional symptoms. The key is 50% of them develop liver involvement. Now remember that lupus erythematosus, systemic lupus, affects every organ in the body except the liver. And if you knew this, you will get the Nobel Prize. Nobody knows why lupus does not affect liver. Now, the lupus hepatitis and all that, I'm not talking about that. I'm talking about irregular systemic lupus erythematosus. Now, there is one area in which lupus can affect liver, and that is when you give them NSAIDs. If you give a patient NSAIDs who does not have lupus, they may not have elevation of enzymes. But if you have a lupus patient, there are organ-specific side effects. There are two organ-specific side effects in lupus patients. One is the liver. You give them aspirin, high dose, they will develop increased ALT, AST. You stop the aspirin, they will go away. The second organ-specific side effects in lupus patients is what is called Motrin meningitis. You give them Motrin or any other NSAID, they will develop or they may develop aseptic meningitis. So it's interesting why it happens, we don't know. If you stop the minocycline, complete resolution may take months to years. It won't go away like many other things. The other key is anti-double stranded and Smith antibodies are present in 15 to 40% of the patients. So this is a sort of an interesting thing. One of the questions frequently asked in many exams is a young lady comes with severe chest pain, a central chest pain mimicking a heart attack, and she has a acne and she takes the medications. What they're asking you is pill esophagitis. Minocycline is known to do that. And the second question on minocycline is this. So we have introduced now 3 drugs in last 2 weeks. One is minocycline, what you have now. Other is hydralazine. Remember hydralazine, we all learned in medical school, causes lupus, but it also causes ANCA-positive vasculitis. And the third drug I introduced last week was propylthiouracil, which can also cause ANCA-positive vasculitis. Next slide, please. A 42-year-old woman is evaluated for a 3-week history of malaise, rash, chest pain, and increasing pain and swelling of the hands. She was diagnosed with seropositive rheumatoid arthritis 4 years ago. That means rheumatoid factor was positive, and appropriately methotrexate was started. Patient started infliximab 9 months ago and did not have recent flare of synovitis, so it is working. On physical examination, she has a fever. Rheumatoid arthritis does not give you fever. 130/80, respiratory rate 18, and erythematous macular rash is noted on the sun-exposed area of the forehead and face. Pleural friction rub is audible on the left lateral chest wall. The PIP joints of both hands are swollen and tender. She started with rheumatoid, she gets on methotrexate and infliximab, and now she develops this. Next slide. CBC metabolic profile CRP are normal, rheumatoid factor anti-CCP antibody and ANA are positive. PPD 6 months ago was negative. Chest X-ray reveals a small left-sided pleural effusion. Don't be fooled by the word small. Effusion is effusion. Which of the following is the most appropriate next step in management? Remember, management could be diagnosis or treatment. Add hydroxychloroquine, add rituximab, discontinue infliximab, or increase methotrexate. Please answer. Okay, I think almost everyone got this, but some people thought to increase methotrexate, a few want to give rituximab. This is infliximab-induced SLE. When I went to medical school, that was a long, long time ago, there were only 2 drugs which cause lupus. Pronestil, which we don't use, and hydralazine, which we use. The last time I checked the list of a definite drug-induced lupus, there are about 50. And the latest addition is the tumor necrosis factor inhibitors. So let's move to the next slide. Anytime a drug is causing a side effects, you discontinue the drug first before you do anything else. I think we had a couple of questions before. A 42-year-old woman is evaluated for a 3-week history of malaise, rash, chest pain, increasing pain, and swelling of the hands. She was diagnosed, I don't know, is this a duplicate slide? Can you go further? Yeah, I think this is for some reason, this is a duplicate. So go to the next one, please. Drug-induced lupus. I just listed a few. The key point I want to make here, and you can look up these slides and what drugs can cause it. My suggestion to you is this. Since over time, from 2 drugs causing lupus to now 50 plus drugs causing lupus, the list has increased. You have to assume that anyone on a new drug developing a lupus-like syndrome, you have to consider that as a possibility. And you may be the first one to report. Anytime I ask my resident, what is the test for drug-induced lupus? And invariably, they will tell me antihistamine antibodies. And I want to remove the myth. Let me read this. Antihistamine antibodies are present in 95 to 100% of patients with drug-induced lupus, but are also found in 50% of patients with SLE, which has nothing to do with drug-induced lupus. Therefore, like anything else in rheumatology, a negative antihistamine antibody is useful in ruling out the disease. So antihistamine antibody has a great negative predictive value for drug-induced lupus. I hope you got that point. It's very important. Next slide, please. So drug-induced lupus, we talked about minocycline, hydralazine, and PTU may also cause ANCA-positive lupus-like syndrome. There's an overlap. It's a vasculitic syndrome. Next slide, please. We must say a word about monoclonal antibodies. There are a whole bunch of them for rheumatoid, but for lupus, we have only one, belimumab or Benlysta. It's a B lymphocyte stimulated protein specific inhibitor. Remember, in lupus, the B lymphocytes get activated and cause all kinds of damage. So we do have one drug. There's not much I can tell you about. I think you should read it yourself. Next slide, please. So summary of SLE. Know the diagnostic criteria. There are 11 of them. Do not make a diagnosis solely on the basis of a positive ANA. Most patients do not require corticosteroids. Most patients. Know the benefits and side effects of hydroxychloroquine. We discussed this in rheumatoid, same thing. Next slide, please. Don't confuse anti-SM antibodies, which is seen in SLE, and SM is Smith, and the anti-smooth muscle antibody, which is seen in autoimmune hepatitis. Next slide, please. What's an overlap syndrome and what is a mixed connective tissue disease? This comes up in rheumatology quite often. An overlap syndrome is what it says, an overlap of A, B, or C. So if you have a rheumatoid, and if you have a little bit of lupus syndrome, like butterfly rash or thrombocytopenia, and you have something else, elevation of CK or muscle enzyme problem, it's overlap because they're overlapping. Mixed connective tissue disease is an overlap syndrome, but must have a specific antibody with it, and that is the anti-RNP antibody. If you do not have anti-RNP antibody, and if you have features of different rheumatic diseases, it is called overlap syndrome. There is no significance of that, except in mixed connective tissue disease, MCTD for short, there is a predilection for lungs, so they get pulmonary fibrosis. In SLE, there is a predilection for the kidneys, so they get glomerulonephritis. Many people believe that SLE and mixed connective tissue diseases are subsets of the same disease. Next slide, please. We are going to go into systemic sclerosis. Next slide. There are 2 forms. There are many, but 2 forms I would like to discuss. There's a limited form. I like the word CREST because that's what I was used to. CREST, C-R-E-S-T, stands for calcinosis. The calcinosis in rheumatology is a big deal. We have our body, bones, teeth are filled with calcium salts. The salt which we are talking about is calcium hydroxyapatite, APPATITE, otherwise called basic calcium phosphate, BCP, same. So there is calcinosis in all places, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, telangiectasia. The key point to remember is that these patients develop pulmonary hypertension without interstitial lung disease. To develop pulmonary hypertension in the diffuse scleroderma, you must have pulmonary fibrosis first. Next slide, please. Diffuse scleroderma, they may have a crest features, but they are less prominent. They develop pulmonary hypertension after they develop interstitial lung disease. They also develop beyond the esophagus. They develop diverticula in the colon. Those diverticula in the colon are wide mouth. They are called Chinese lantern diverticula. And because they are wide mouth, they do not get stools in and in, the stools come out, and therefore they do not get diverticulitis. So the incidence of diverticula is high in diffuse scleroderma, but the incidence of diverticulitis is low. The key question comes up in the boards and any other exams is the scleroderma kidney. So I'm going to talk about this. The other way to distinguish between diffuse scleroderma and limited or crest is tendon rubs. So if you take a patient's hand and put your hand on the tendons and you move the patient's hand, and you will feel rubs. Just like in osteoarthritis, you feel crepitus, you will feel the same rub over the tendons. If you see that, patient has a diffuse scleroderma. If the sclerosis occurs proximal to the wrist, it is called proximal scleroderma, and that would mean patient has a diffuse scleroderma. Next slide, please. There is a serological difference between those two. In diffuse, you have SCL70 antibody, otherwise called anti-topoisomerase 1. In the limited form, you have anti-centromere antibody. Both antibodies do not ever occur together. If they do, it's a lab error. Next slide, please. A 36-year-old man is hospitalized for acute kidney injury and hypertension. He was given IV labetalol and hemodialysis was initiated. He has a 5-year history of diffuse cutaneous systemic sclerosis. His only medication is omeprazole, probably because of the heartburn and esophageal dysmotility. Temperature is 97.8, blood pressure is 140/70, heart rate is 70, respiratory rate is 18. Regular rhythm, no extra sounds. He has bibasilar crackles. Skin examination shows sclerodactyly of the both hands, as well as skin induration of both forearms and anterior chest. That makes it diffuse. Next slide. Is anemic, 28 hematocrit, white count is 4,900, platelet is low, B1 is up, creatinine is up, 40/5.2, LDH is 480. Peripheral smear shows several cystocytes. Cystocytes means decapitated RBC, and that means there is something going on in the small vessels, which is chopping off the RBCs, and they are typically fibrins products. Kidney ultrasound reveals normal sized kidney and no heteronephrosis. Next slide, please. Which of the following is the most appropriate treatment? Now, mind you, they're asking you treatment, they're not asking you diagnosis. And they already told you the patient has diffuse scleroderma, but they want you to diagnose and treat. So, bosentan, lisinopril, plasma exchange, sildenafil. Please answer this question. Okay, here we have some issues. It's all over. Some people want to give bosentan, lisinopril. I think to answer this question, you have to know the pathogenesis. If you can go to the next slide, please. Scleroderma kidney is a distinct rheumatological emergency. We don't have too many emergencies in rheumatology, but this is one of them. The key point to remember, there are many, but the key points I would like you to note is the risk is increased in the first 2 to 3 years of onset of diffuse scleroderma. It does not occur in limited or crest. So what's the learning point? If you have a patient with diffuse scleroderma, please do not prognosticate for 3 years. Let it go, because you don't know how the body will react. Second, it causes malignant hypertension. The definition of malignant hypertension is hypertension severe plus papilledema. That is, then it is called malignant hypertension. And there are other causes too. The pathogenesis of this is severe activation of renin-angiotensin system. It just goes crazy. There's an intense amount of vasoconstriction in the kidney, throwing renin out, causing severe hypertension. If anybody asks you trivia question, which medical condition has the highest renin, your answer will be scleroderma kidney. Because there is a widespread thrombosis in the small vessels and fibrin products are formed, and the RBCs have to squeeze through those vessels, they are decapitated. That's why you see cystocytes. Typically occurs in cold weather because you all know the Raynaud's phenomena occurs with cold. Learning point here is keep the patients warm. If you have such a patient, give them extra blankets and keep them warm. And the treatment, because it is a high renin situation, is ACE inhibitor. What kind of ACE inhibitor? All the studies, early studies, and even recent ones are done on captopril. We don't use captopril much, but there is some suggestion that captopril may be better. And the typical dose of captopril is about 50 milligrams 3 times a day. In this condition, you use around 500 to 1,000 milligrams a day, enormous amount. If you don't, your patient will be on dialysis. I think this patient was already on dialysis. Next slide, please. I like this picture. It's a postmortem angiogram of a person on the left who died from a car accident, and you see the vasculature. The postmortem angiogram of a patient who died from or had a kidney removed in a scleroderma kidney, you can see the vessels are so constricted that nothing is flowing. And if the kidney is ischemic like that, it will throw a lot of renin-angiotensin into the circulation and elevate the blood pressure. It's a very interesting photograph of a postmortem sample. Next slide, please. Raynaud's phenomena, very common. We all see it, but there are certain things we must know. It's a sequential color change. The first is white because the blood is taken, blood stops moving. Then it becomes blue because the blood is stagnant. And then it opens up, there's hyperemia, is red. In fingers usually following exposure or emotion. We forget the emotion part. The way to describe Raynaud's, we don't do this, even rheumatologists don't do this, but you should say patient has Raynaud 1, Raynaud 2, or Raynaud 3. Raynaud 1 means 1 color, Raynaud 2 means 2 colors, Raynaud 3 means 3 colors. Why? Because it distinguishes from a benign nuisance Raynaud versus a significant Raynaud having a major disease. Raynaud disease is a Raynaud phenomena without an underlying pathology, just Raynaud's, nothing else. It is an estrogen-dependent phenomena. Therefore, it occurs in menarche and ends at menopause. Men should never get Raynaud's. If man gets a Raynaud's, you need to work him up. If a woman post-menopausal gets menopause, you should work her up. The question asked every time in all kinds of exam is, what do? You have a patient with Raynaud's, they will give you ANA, DNA, complement. The correct answer is nail fold capillaries. Examination, you can do it in your clinic with an ophthalmoscope. Remember that many patients with Raynaud's, not many, some would have a positive ANA, but not lupus. Next slide, please. This is the nail fold capillary. The picture on the left is a small dissecting microscope. You put it around the nail bed and you will see the capillary loops. They all are abnormal. Absolutely, they are dilated, they drop off, they are aneurysmal at times. If you see this, this is not a physiological normal Raynaud's, which is a nuisance. By the way, the incidence of nuisance Raynaud, what I call nuisance Raynaud, is 20% in menstruating women. That's high. And some of those women will show up in your office and complain. How do you know it is just a nuisance Raynaud's or there is some underlying connective tissue disease? This is the test you do. Next slide, please. Sjogren syndrome is a chronic progressive inflammatory, the best word I have for Sjogren, autoimmune exocrinopathy. Commonly, we say keratoconjunctivitis sicca, but that limits us to only eyes only. Exocrine glands are everywhere. So they have dry eyes, dry mouth, dry nose, dry trachea, dry bronchioles, dry intestinal secretions, dry vagina, and therefore they have symptoms all over. Parotid enlargement is just one of the many. The key to remember in Sjogren, there is a primary Sjogren and there is a secondary Sjogren. Most rheumatic diseases, rheumatoid arthritis, lupus, scleroderma, they have secondary Sjogren. But there's a primary Sjogren without anything else, and they can get chronic arthritis, interstitial nephritis, type 1 RTA, and they can also get vasculitis and interstitial lung disease. That's a primary Sjogren. In secondary Sjogren, you typically do not get any of those. Next slide, please. So dry syndrome, there's an increased risk of lymphoma in patients with Sjogren, particularly primary. They have positive anti-nuclear antibody, anti-Rho and anti-La. We already talked about anti-Rho in the subcutaneous lupus, chronic subcutaneous lupus. Treatment is to increase the tear formation, increase the saliva formation. Not much available. Pilocarpine is used to improve the moistness of the mouth. Ocular cyclosporin, the restasis drops you hear about, that works sometimes, but really the treatment is not very effective. Next slide, please. If you see skin thickening without Raynaud, it is not systemic sclerosis. In systemic sclerosis, Raynaud is 100%. So there are conditions which cause thickening of the skin. The most common condition which causes thickening of the skin is diabetes. We will, next session, we will have discussion on diabetic chiro-arthropathies. Next slide, please. I think we are going to do myopathies and then conclude this session. We have 7 minutes left. The next slide, please. Let's get first to statin myopathy because that's the commonest myopathy you and I will see. Statin myopathy has a spectrum. It can cause myalgia with elevated CK. That's the classic form. It can cause myalgia with normal CK. Many years ago when statins came out, we knew myalgia occurred. We checked the CKs. CKs were normal and we told people it's your imagination. It's not statin, but it can be statin. That's the point. It can cause frank myositis, leading to acute rhabdomyolysis. Depending upon the statin you use, the incidence can vary. Pravastatin has the lowest incidence because it is water soluble and therefore lowest incidence. Torvastatin and rosuvastatin, the high intensity statins, have higher incidence. The risk factor for statin myopathy is chronic renal failure, obstructive lung disease, and hypothyroidism. One should never start statin without checking the TSH. Statin also interact with number of drugs. The one I want to alert you is statin and erythromycin. Patient has coronary artery disease, hyperlipidemia, is on a statin and few other things, comes to the emergency room with pneumonia. Now you're going to start him on azithromycin. You must discontinue statin. I always tell my residents there are 2 drugs you discontinue on admission. One is a statin, other is a metformin, because you don't know what's going to happen tomorrow. So unless there is a compelling reason to continue statin, statin should be discontinued when you give azithromycin. Next slide, please. We're going to talk about polymyositis and dermatomyositis and inclusion body myositis. They are diseases, they are different diseases, even though they are lumped into one title. So polymyositis and inclusion body myositis are diseases of cellular immunity. whereas dermatomyositis is a disorder of humoral immunity. This has an implication because we are going to use rituximab at some point, which is a cellular immunity. So there is a difference among them. Next slide. Inclusion body myositis is one of the favorite questions. Here is an elderly man falling. It affects older men for some reason. The onset is very insidious. The patient does not even know when it started. And onset is proximal asymmetric weakness. Now, asymmetric means difference between left and right. In polymyositis, you have symmetric weakness. In inclusion body myositis, there is asymmetric weakness. But there's also another asymmetry, and that is between the flexors and the extensors. In a polymyositis, both flexors and extensors are weak. In inclusion body myositis, one group may be weaker than the other group. Other difference is distal muscles are involved, hand muscles. Irrespective of what you do, the disease is progressive and does not respond to any treatment. The other thing about this condition, there are no systemic features, rashes and things like that. And if you do an EMG, as you will do in other myopathies, you will not only see myopathic abnormalities, you will also see neuropathic abnormalities. So this is a myoneuropathy. And biopsy on the regular microscope shows vacuoles, on the electron microscope shows inclusions. Therefore, it is called inclusion body myositis. Next slide, please. I have three pictures here. The picture on the left is a person with a proximal muscle weakness. Remember, polymyositis, dermatomyositis cause proximal muscle weakness because that's where most of your muscles are, quadriceps, vastus, deltoids, etc. So the woman has difficulty climbing stairs. She cannot get out of chair. The picture in the right is the muscle biopsy. You can see the muscle fibers and you can see a lot of inflammatory cells. The picture of the middle is my favorite, and my question to you is, I don't know whether you can answer this or not. This is a 21-year-old man had a motorcycle accident and comes in and has aches and pains, different parts of the body. X-rays were taken, and this is what you see. What's the diagnosis? This is childhood healed dermatomyositis. For some reason, doesn't happen in adult. For some reason, when a child gets dermato or polymyositis, the healing occurs by calcification. I know that in the exams, they have asked this question, they showed this picture. I don't know how popular it is now. It's an interesting thing to remember. Next slide, please. I like the Pearson classification. It's old. I don't know how many people are using, but I think it's useful. And this is as follows. It's adult polymyositis, adult dermatomyositis, which is polymyositis plus skin, or third, polymyositis, dermatomyositis associated with cancer, separate entity, childhood polydermatomyositis, and lastly, polydermato associated with connective tissue disease such as lupus. What is the advantage of this classification? I'll tell you why. If the dermatopoly is associated with cancer, the treatment is to treat the cancer. Dermatopoly will go away. It's a paraneoplastic syndrome. If the person has lupus, treat the lupus. Don't treat polydermatomyositis. So that person may qualify for hydroxychloroquine. If it's a child, we don't do children, we don't see children, but if it's a child, the incidence of malignancy is extremely low. So you don't have to do a lot of tests to detect a malignancy. Next slide, please. The diagnosis of polydermato is made clinically, and the chief complaint of polymyositis is not pain, but weakness. This is the only itis which does not give you a lot of pain. They may get little sore muscles, but not a lot of pain. Second is chemical. CK is fine. You don't have to do aldolase because I see a lot of time aldolase is done, not necessary. Please remember that ALT and AST are not liver specific. So in a polydermatomyositis, you may have increased ALT and increased AST. There are muscle enzymes. When my residents tell me liver enzymes are abnormal, I ask them, why do you say it is liver enzyme? Electrical, you do EMG, you insert needles and you see a myopathic potential. Serological, there are some antibodies, we'll talk about that in a minute. And finally, histological. Please note that you don't need all 5 to make a diagnosis. Next slide, please. This is a page we are going to go through some. I am already 7:01, so please forgive me for exceeding this. This is the so-called heliotropic hue. Look at the upper eyelid on this woman. It is a heliotrope color. The heliotrope is a flower, which I showed you on the right. It's a purple magenta type of color, beautiful color. And that is fairly classic of dermatomyositis. Next slide. This is the shawl rash, which is exposed to the sun area skin. This could be lupus. It doesn't have to be dermatomyositis. It could be lupus. Next slide, please. These are the classic Gottron's, Gottron papules. They look like psoriasis. Many times they are treated as psoriasis. They occur on the extensor surface of the joint. Here it is in the hand, but they can occur on the knees and the elbows. Next slide, please. This is a mechanic's hands. A true mechanic may have a hands like this. You see the rough fingers. But if this happens to be a professor or a businessman, then this is abnormal, mechanic's hand. And that goes along with dermatomyositis. Next slide, please. So this is the serology. You have anti-J, anti-Jo antibody, which correlates with interstitial lung disease and mechanic's hands. So they might give you a picture of mechanic's hands and ask which antibody is associated with this, and that would be anti-Jo or anti-synthetase. There is an MI2 antibody, which goes along with skin involvement. I don't think you need to remember the next two. I think I'll skip this and go straight to the next question. Next slide. This is the end of part 2. I thank you for your attention. I don't know whether you can ask questions. There's a lot of chat things here.
If anyone would like to ask a question, just feel free to put it in the chat or raise your hand.
Can we repeat the lung syndrome again? I did that. Thank you so much. Polymyositis, SLE, systemic sclerosis. Thank you. Oh. Can you repeat the side effects of NSAIDs again? I only wanted to be, if I do all of them, you will be here till 8 o'clock. I think the most important one we should know is the sodium retention, therefore hypertension, edema, and heart failure in a compromised patient. You all know gastric side effects, peptic ulcer disease, GI bleed. But the one I wanted to emphasize was a patient who is on chronic cancer therapy may get a diaphragmatic lesions in the ileum, giving bowel obstruction. The second, not very commonly known, is microscopic colitis. Please feel free to raise your hands. Okay, does the CV effect of side effects of Jacob? Okay, I think I answered that. Raise. Can we repeat the lung? I did that.
You've captured them all.
Okay, thank you. Okay, I appreciate your feedback. I think there will be a formal evaluation. So I really need to know, because I've done this course live in the past ACP courses, but I've never done it on Zoom. And I think I lose something, because in Zoom, I can actually tease you. I can actually point fingers. Here, I can't do that. So any feedback would be greatly appreciated. John, are you still there? No, okay. We will meet again for this third session, I think next week. Thank you all.
Nayan, I just want to say thank you. It was an excellent presentation. Can you hear me?
Yes, I can hear you.
I just want to, I think actually on Zoom, the question answer is very nice. It's a little less intimidating, where I think we can feel like we can be wrong. And and still learn. So I think Zoom works quite well. And I think that you can use the chat in terms of taking questions in real time if they come up as the technical support will remind you. But I think it worked quite well. And the images were very well projected. And so I enjoyed it. Thank you for an excellent review.
Thank you, John. Thank you.
Thank you, everyone. We will see you next week.
Thank you,
Have a great
Cynthia.
night.
Thank you, Teresa. Thanks, everybody.